Is everybody here?
Doctor, there's some like 2% still not here. I will be presenting the slide.
Ada berapa orang yang tak ada? Patutnya berapa orang?
Sorry, Doctor?
Patutnya? Patutnya berapa orang? How many people in your class?
38.
So, that's 3 lah. Kalau tak, start je.
Okay. Start.
Start je.
Okay, good. So today we are from seminar 8. We'll be presenting seminar under the topic of respiratory diseases in pediatric. So without further ado, let us jump to the seminar.
Okay, good afternoon. I bid to Dr. Chan and all my fellow friends. Can you guys hear my voice?
Yes.
Okay, thank you. So my name is Nur Fazil Zinira binti Fazil and I'm going to present about the bronchial asthma. Next. So this is my outlines. Next. Okay, for the definition of the bronchial asthma, it is a chronic airway inflammation that leads to the increased airway responsiveness and can cause recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly at night or early morning. It is a reversible and variable airflow limitation, as evidenced by more than 20% improvement in peak expiratory flow rate or more than 12% improvement in forced expiratory volume in 1 second in response to administration of a bronchodilator. Next. So based in United Kingdom, it is the most common chronic respiratory disorder in childhood, which affecting about 15 to 20% of the children, and the incidence has become significantly increased over the last 40 years. Next. Based on the CPG Management of Childhood Asthma 2014 of Malaysia, the prevalence seems to have been plateaued in Malaysia. There is about 5.8% in 6 to 7 years old, 8.9% in 13 to 14 years old, and 7.14% in up to 18 years old. The incidence is higher for children who live in the urban and inner city compared to the children who live in the rural area. Next. For the etiology, it is caused by the genetic predisposition. The incidence will be higher if the child has first degree relative who having the asthma. In the genetic predisposition, there will be T helper cell that hypersensitive to the allergens. The second one is atopy, for example, like asthma, eczema, and also allergic rhinitis. And the last one is the environmental triggers. Okay, next. So the example for the environmental triggers, including the upper respiratory tract infection that caused by the virus such as rhinovirus and also respiratory syncytial virus, the allergens like house dust mites, grass pollens, and pets, smoking either it is active or passive, the child who exposed to the environmental tobacco smoke will have more frequent and severe asthma exacerbations. And then cool air, exercise, any strong emotions like laughing and crying, any chemical irritants like pain and also aerosol, and the last one is food and medication allergy. The usual food that can cause the allergies such as cow's milk, egg, soy, and so wheat, but it will be resolved in the most children by 5 years old. However, the allergy to the peanuts, fish, and also the shellfish generally persists. Next. So this is the pathophysiology for the bronchial asthma. Next slide. Basically, the bronchial asthma is the under type 1 hypersensitivity. So in type 1 hypersensitivity, when there is first exposure to the allergen, the antigen presenting cell, such as macrophage and also dendritic cell, will present it to the CD4 plus T cell. So this T cell will differentiate into the T helper T cell. The T helper T cell will release interleukin 4 that will stimulate the B cell. So the B cell will differentiate into the plasma cell and produce the IgA antibody. This IgA antibody will bind to the mast cell, and this first phase is known as a sensitization phase, and no any reaction until if there is subsequent exposure. It just same with the humoral immune response, but the difference is that it will produce IgE instead of the IgG. Then if there is subsequent exposure, so the allergen will bind to the IgE molecules on the mast cell. This cross-linking of the IgE will activate the mast cell to degranulate and will release the histamine, serotonin, and leukotriene that will cause smooth muscle contraction, increase in the vascular permeability, and mucus production. Previous slide. So if there is the triggers, so this can cause bronchial inflammation that characterized with edema, excessive mucus production, and also the infiltration with the cells. So the bronchial will be hyperresponsiveness and it can cause the airways to be narrowed. So the patient will present with the symptoms. Next. Okay. During the asthma symptom, there will be narrow airway, muscle constriction, thickened airway wall, and also excessive mucus production. Next. Here for the diagnosis, the clinical we can do the diagnosis based on the clinical manifestation. The asthmatic child will present with the recurrent episodes of one or more of the following symptoms, including the coughing, which usually nocturnal and exacerbated at the early morning, and then wheezing. So any child with wheezing on more than one occasion, we should be suspected with asthma, and then chest tightness and the shortness of breath. Next. So in the history taking, we should ask about the pattern of the symptoms, including the either it is worsen at night or early morning or throughout, the frequency, and also the symptomatic improvement. And then any triggering factors like exercise, upper respiratory tract infection and PETs, any risk factor like atopic and parental asthma, the past medical history like previous hospital admission and exacerbation history, social history like the number of the school missed, and also the limitation on daily activity. Next. So for the physical examination, I provide you guys a video.
Mm. Who's the one sharing the video? I think you have to fix the audio.
I think can Zaid unmute yes, unmute the
Hmm. Right, maybe pause it for a while. Is the video as long as it can go? Zaid, oh Zaid,
Yes.
do you hear the audio? Do you
Uh,
hear the audio?
yes, I can hear the audio. Let's play from my.
Everybody else dengar tak audio? Tak dengar kan?
I think
No, tak dengar.
No. Cannot hear the audio.
I have unmute my.
See whether you left out something like that.
Sure.
The purpose of this video is to provide general information and education about the care of a critically ill. Zaid, you stop
Yes, sir.
sharing for a while. You stop sharing for a while. Who's the presenter?
Yes.
You stop sharing for a while. Who's the presenter?
Sorry, Doctor.
Siapa presenter tadi?
Faza.
Fazal nak tengok semua ke apa video ni?
yeah?
Are you gonna play the whole thing or what?
Yes.
You. Okay, Zaid, stop sharing for a while.
Stop sharing.
Fazal, stop sharing. Fazal, you're sharing. Stop sharing, yeah.
Okay.
Fazal, stop.
one, right? Hold
Asthma comes from the Greek word for
Sorry.
It makes sense because it causes chronic inflammation of the air. Critically ill child. It is in no way a substitute for the independent decision-making and judgment by a qualified healthcare professional. The information contained in this video should not be used to make a diagnosis or to overrule the advice of a qualified healthcare provider, nor should it be used to provide advice for emergency medical treatment. Clinical exam findings in asthma by Dr. Tracy Wolfland. Please note that in this video we will be following the guidelines.
Fadla, is it this video?
Yes,
Fadla,
doctor. Yes, yes.
can you guys hear me? And the rest of the class here?
Yes.
Yes.
So you want the whole video then, Fadla?
Yes.
Austin Children's Hospital. Some of this information may need to be modified based on the equipment, guidelines, and practices in place in your institution. Hi, my name is Tracy Wolfland, and I'm a pediatric intensivist at Children's Hospital Boston. In this video, I'll be talking to you about the clinical assessment of a patient with asthma, specifically an asthma exacerbation or a patient in status asthmaticus. In this video, I'll be talking to you about the general assessment of a patient with asthma. We'll take a look at the vital signs of a patient with an asthma exacerbation or status asthmaticus. We'll discuss the pulmonary or lung exam findings that you might notice in a patient with asthma, as well as some of the other cardiovascular signs and symptoms. I'll be explaining one way of how to clinically assess a patient with asthma exacerbation or status asthmaticus. General assessment. So the first thing that I do to examine a patient that has an asthma exacerbation or status asthmaticus is to look at the general picture of the patient. I want to assess the mental status and activity level of the patient. Is the patient awake? Is the patient vigorous and playful? Or is the patient drowsy, irritable, or even unconscious? The patients that are drowsy, irritable, or unconscious, I would be very worried about this patient. All of these signs, irritability, unconsciousness, obtundation, so the patient that's not responsive to pain or touch, all of these will make me extremely worried about a patient with an asthma exacerbation. Additionally, you may want to see how well the patient is able to speak. Can the patient put together multiple words in a sentence? Or is the patient so dyslexic that they can only speak one or two words at a time before having to take a break? A patient that can speak complete sentences makes you less worried than a patient that can only speak one or two words at a time. And that will also give you a marker and an indicator to measure the patient's clinical improvement over time. Vital signs. The next thing we'll look at is what is the patient's vital signs. Typically, a patient with asthma who has an asthma exacerbation or is in status asthmaticus, these patients will typically be tachycardic, often are quite tachypneic, and they may or may not have low oxygen saturations. They often are hypertensive, and so you want to take a look at all of these vital signs to help you redirect your therapy. The patient's tachycardia is likely coming from the catecholamine surge that the patient has because of their struggling to breathe. It can also be related to some of the therapies that we use to treat asthma, such as beta agonists. The increased respiratory rate is often a function of the patient having difficulty moving air in and out, which is related to their asthma. The low oxygen saturations may be related to the asthma exacerbation itself, or it may be related to the underlying process that's leading to the asthma exacerbation, pneumonia, or a viral infection. And so search for these causes is often warranted. And finally, the hypertension or high blood pressure, again, is often related to catecholamine surge from the patient being unable to breathe, as well as potentially hypercardia, which can lead to hypertension. So you want to make a mental note of what their vital signs are and what their vital signs should be for their age normal. Pulmonary findings. So once I've globally looked at the patient and I've looked at their vital signs, the next thing I want to do is actually examine the patient. So I'm going to take my stethoscope here and I'm going to listen to the patient. I'm going to listen anteriorly and on the anterior side, inferiorly and superiorly, as well as I want to listen posteriorly to these patients. And again, listening inferiorly and superiorly. I want to listen for air movement. Is the patient able to move air, or is their air entry extremely diminished? I want to listen for wheezing. Does the patient have inspiratory wheezes or expiratory wheezes, or both? I want to take a look at the patient's field of breathing. Some of the signs and symptoms that I pay specific attention to are the presence of nasal flaring, the presence of grunting, the presence of suprasternal retractions, also called tracheal tugging. If there's any intercostal retractions, or if there's subcostal retractions, or chest and drawing, as it's sometimes called. All those would be signs and symptoms that you can use to both monitor the clinical course of each patient with asthma, as well as to help you determine how sick the patient is. A patient that has a quiet chest and really low air entry should make you very worried about the patient. A patient with a lot of wheezing but good air entry should make you less nervous, because this means that the patient's at least able to move air in and out of their chest. Patient without air entry and with no audible wheezing is not moving very much air at all, and likely may have an impairment of their oxygenation and or ventilation. You can also look at the abdomen to see if there is paradoxical movement of the abdomen and chest, indicating that the diaphragm is working very hard to help assist this patient with breathing. Cardiovascular signs and symptoms. Finally, you want to assess the patient's pulses. Oftentimes, in patients that have severe status epilepticus, you may often notice that you feel pulsus paradoxus. So, clinically, what this means is that if a patient inspires and they're taking a very large negative pressure breath, creating a large negative intrathecal pressure, this is helping to pull blood from the inferior vena cava, the superior vena cava, into the right side of the heart. But in asthma, there are two other factors that will affect the amount of blood returning to the heart. One is that the patient is often clinically dehydrated, and the patient with asthma often has hyperinflated lungs. So these three factors, dehydration, hyperinflated lungs, and negative intrathecal pulses, will overall determine the amount of blood that's returning to the heart. And if the right ventricle becomes distended with this large amount of blood, it actually goes over into the left side, creating less blood volume for the left ventricle to squeeze out to the body. Additionally, this large negative interthoracic pressure creates more work for the left ventricle to do, and thus, during inhalation, it's more difficult to maintain adequate cardiac output. And so we'll often appreciate a clinical decrease in the blood pressure and a clinical decrease in the cardiac output during inspiration. And this should make you also quite indicates that the patient's status asthmaticus is quite severe. Clinical care. You can also observe corticosteroid in the patient's monitor by looking at the pulse oximetry tracing and arterial blood pressure tracing if they have an arterial line in place. You can see that during inspiration, the amplitude of the tracing decreases, reflecting the decreased cardiac output during inspiration. This will resolve as the patient's clinical condition improves. You also want to assess the patient for signs of dehydration. These patients are often breathing fast, and breathing deep, and breathing hard, often for several days before they present to the hospital. And so they can often be quite dehydrated. So looking at their mouth to see are their lips dry, is their tongue dry. Although not a very good indicator of a patient with respiratory disease, it might make you think about dehydration. You'll also want to look at perfusion. So what is the capillary refill time if you check extremities or if you check the chest? You could look at skin sugar and you want to look at their pulse and other vital sign indicators. If the patient is hypertensive, that might be another indicator that they were quite dehydrated. If they're an infant, you can feel the fontanelle to see if the fontanelle is sunken or is it bulging. If it's sunken, it should make you worry again about dehydration. This concludes the video on the clinical evaluation of a patient with asthma who's presenting with an asthma exacerbation or status asthmaticus. Please help us in clinical contact.
Okay, done. Father, you want to continue your presentation?
Okay, next. Okay. For the diagnosing asthma in the preschool children is difficult. So we have two main categories of phenotype of the wheezing. The first one is transient early wheezing, or also known as virus-associated wheeze, episodic viral wheeze, or wheezy bronchitis, which this type of wheezing is caused by the viral infection that can lead to the immune response and inflammation. So the small airways will be narrow and obstructed. It is episodic in nature, so the patient will be well between the episodes. It is common in males and will be resolved by 5 years old because it is made due to the increase in the airway size. It is triggered by the virus that can cause common cold, and the risk factor for this wheezing is the maternal smoking either during or after the pregnancy and also the prematurity. The family history of the asthma or allergy is not the risk factor for this type of wheezing. So the patient may have decrease in lung function from birth. The second type of wheezing is the persistent and recurrent wheezing, where there is presence of the IgE and eosinophils, two common inhalant allergen. So the patient will have persistent symptoms and symptoms in between the episodes. In patient who have positive skin prick test or IgE blood test, it is known as atopic asthma. This can cause by triggered by many stimuli and usually associated with other atopic disease such as eczema, rhinoconjunctivitis, or food allergy. So the patient may have a decrease in lung function. Next. So this prevalence of wheeze in the children that caused by the two major phenotypes by the age where the transient early wheezing is usually in the early childhood. Meanwhile, for the IgE associated wheeze, highest at after the 6 years old. Next. So we have asthma predictive index that can be helpful to predicting the asthma in the young children. So the positive predictive index means that there is a 65% chance of having asthma by the age of the 6 years, and negative predictive index is the child will have 95% of chance of not having the asthma. The positive index means if the child have more than 3 wheezing episodes per year during the first 3 years, plus one major criteria or 2 minor criteria. For example, of the major criteria are the eczema, parental asthma, and positive aeroallergen skin test. And for the minor criteria are like positive skin test within the upper respiratory tract infection and also eosinophilia more than 4%. Next. Meanwhile, based on the PATS protocol, to diagnosing the asthma in child who is less than 5 years old, we can use this table to know the probability of the asthma based on the duration of the symptoms, the number of the exacerbations, the interval symptoms, and atopy of family history of the asthma. So the low probability will have less than 10 days of symptoms. 2 to 3 number of exacerbations per year, no interval symptoms, and no family history of the asthma. For the moderate, the symptoms are more than 10 days, more than 3 number of exacerbations per year, having occasional cough or wheeze, and no family history of the asthma. And for the high probability of the asthma, if the symptoms is more than 10 days, having more than 3 number of exacerbations per year, having cough, wheeze during play, laughing, or exercise, and presence of the family history of the asthma. Next. Okay, for the investigation, we can do bronchodilator reversibility test, which it is a test to measure the pulmonary function by using the spirometry and also the peak flow meter. It is used in the child who is more than 5 years old, who can perform the spirometry maneuver. Meanwhile, for the less than 5 years old, who cannot perform this maneuver, we will give the therapeutic trial of the medication. So to perform this test, before the bronchodilator is given, we must measure the forced expiratory volume in 1 second. And then after that, give the bronchodilator by the metered-dose inhaler of the spacer. And then these bronchodilators need to be withheld for at least 4 hours prior to testing. So in bronchial asthma, there should be improvement where the forced expiratory volume in 1 second is more than 12% and the peak expiratory flow is more than 20%. Next. Other investigation that we can do is the fractional exhale nitric oxide, which it is done if the diagnosis of the asthma is uncertain, or we want to know either the steroid medication is working or not. So the nitric oxide is will produce throughout the body, including the lung. So if there is high nitric oxide in the exhale breath, it indicates that there is airways inflammation. And then we also can do the skin prick test in the child having the persistent asthma, and then the chest X-ray, but it's only indicated in the first episode of asthma. Any fever or any symptoms that indicate pneumonia, any finding of physical examination that suggests other diagnosis, marked respiratory distress, although child with no family history of asthma or atopy, suspected congestive heart failure, and also the history of the trauma. Next. Here for the management, the aim of the asthma management is we want to maintain the normal activities, no absence from school, no visits to the emergency department or any hospitalization, no mortality, and also no side effects from medication. This management should be individualized because each patient will have different trigger factors, asthma phenotypes, and also different response to the medication. Next. Okay, we should educate the patient by explaining the nature of disease and its treatment, tell the patient about the signs and symptoms, avoiding the trigger factors, and understanding the cause mechanism of the disease, inform about the medications, instruction on the self-management, and also education on exercise. Next. For the prevention, if the child had been known with any allergy to any allergens, so we should prevent the child from exposed to this. For example, in smoking and air pollution, we should avoid we should avoid the child from this exposure, as this can develop asthma, as this is one of the risk factor for the child to develop the asthma at any age during the childhood, including if the child is still in the gestation. So the clinicians should routinely inquire about the parental smoking and advise that the home and also the motor vehicles should be no smoking zones. If the child had been known with the environmental allergens, so there are some measures that can be taken. For example, like if there is allergy to the house dust mite, we can advise the patient to use allergen permeable mattress or pillow covers, wash bedding in hot water, reduce indodampness and humidity and others. If pets, so remove the pets, or if impossible, so can exclude the pets from the bedroom or use the HEPA filtration. If cockroach, so regularly clean the home and use the professional pest control. And for the molds, wash the moldy surface with bleach solution and many more. Next. Okay, for the exercise, so the exercise is also one of the trigger for the child to having the asthma, but it's still encourage for the children to exercise for their growth and development. So the child needs to take the beta-2 agonist and optimizing the treatment. If there is exercise intolerance, it indicates that they may be inadequate asthma control. Next. Okay, for the drug therapy, we have reliever therapy, for example, short-acting beta-2 agonist, for example, like salbutamol and terbutaline, which the mechanism of administration is by the inhaled route because it has less adverse effect, for example, like tremor, prolonged tachycardia, and also irritability. It will relax the bronchial smooth muscle within 5 to 10 minutes of administration and used for the acute symptoms and also prophylaxis. If there is overuse, it indicate that the patient have inadequate control or poor control of the asthma. The overuse is depends on the patient severity and also can be defined as more than 1 meter dose inhaler per month or more than 8 puff per day. Next. Another reliever therapy is the anti-inflammatory agent, for example, like apratoprine bromide, to relieve the bronchial constriction and also decrease the mucus hypersecretion. And the last one is the oral corticosteroid, but it is discouraged because of the neurotherapeutic index and have systemic adverse effect, for example, like HPA suppression, Cushing features, weight gain, hypertension, and growth suppression. Next. Okay, for the preventive therapy, we have inhaled corticosteroid, which is the treatment of choice and the most effective anti-inflammatory medication. It is used for the long-term control therapy, multi-trigger wheeze, and also the atopic asthma. It is available as inhalation aerosol, dry powder inhaler, and also nebulizer solution. And the potential risks are favorably balanced with their benefits. If the patient just use low to medium dose, it may cause the patient to decrease in the growth velocity, but it may not progressive and may reversible. The patient may have local adverse effect, for example, like dysphonia, candidiasis, and also decreased systemic absorption of the GIT, but this can be lessened by rinsing the mouth and using the spacer. No clinically significant adverse effect. Next. Then we have leukotriene receptor antagonists like Zafilocas and also Montelukast for the long-term preventive therapy, intermittent causes in episodic viral wheeze, and also mild persistent asthma. Next. And then long-acting beta-2 agonists. So this long-acting beta-2 agonists should be used as a combination therapy with the inhaled corticosteroid and shouldn't be used as a monotherapy alone. We need to monitor if the asthma is controlled at least 3 months, and if it is controlled, so we can withdraw the LABA and use the minimum dose of the inhaled corticosteroid. Next. Okay, so this is a picture for the asthma drug therapy. Next. Okay, and then inhaler devices. Inhaler devices must use appropriately according to the age of the patient. In the less than 5 years old, we can use oral, metered-dose inhaler and spacer with mask. In 5 to 8 years old, we can use metered-dose inhaler and spacer with mask. And meanwhile, for more than 8 years old, we can use MDI and spacer with mask or with mouthpiece and also dry powder inhaler. Next. We also need to educate the patient on how to use the metered-dose inhaler with the spacer. So first one, we shake the medicine, and then after that, insert the mouthpiece of the inhaler to the rubber seal end of the tube aero chamber. Breathe the air all the air out of the lungs and put the chamber into the mouth. Make sure that the seal is tight, and then press the MDI down to release the spray of the medicine. So the medicine will be trapped into the chamber. And then the patient need to breathe in slowly and deeply. After that, hold the breath for at least 5 to 10 seconds and breathe out slowly. Next. And then for the management of the acute asthma, it will depend on the severity at the presentation and respond to the therapy. So investigation like ABG is only done for the acute severe asthma. Meanwhile, for the chest X-ray, it's not really helpful unless if there is suspect complications. The criteria for the admission for the patient, if the patient is failure to respond to standard home treatment, failure to respond to nebulized beta-2 agonist, relapse within 4 hours of nebulized beta-2 agonist, and severe acute asthma. Next. So this is the assessment of the child with the acute asthma, which is based on the 9 parameters. We should look if the patient breathless, can talk, alertness, the respiratory rate, any accessory muscle usage, any wheezing, SpO2, pulse per minute, and also peak expiratory flow rate. Next. So this algorithm for the management of the bronchial asthma in the children, and also the drug dosage for the medication in the acute asthma. So basically in the mind, we need to administer the nebulized salbutamol or MDI salbutamol and also oral prednisolone. Then review after 20 minutes. If there is no improvement, so we indicate this patient is having moderate asthma. So we give the patient with nebulized salbutamol, add on with the apratoprine bromide, oral prednisolone, and also oxygen. If there is no improvement, so admit the patient to the hospital. Next. Okay, otherwise, other thing that we need to monitor in this patient is to monitor pulse, color, PSPT flow rate, ABG, and also oxygen saturation for at least 4 hours, hydration, and then the therapies that not recommended like antibiotics, unless if there is infection, sedative, chest physiotherapy because it can cause discomfort to the patient, nebulized magnesium sulfate, antihistamine and mucolytics because it can exacerbate the coughing of the patient, adrenaline injection and also nebulized hypotonic saline. And then on discharge, we provide the asthma action plan to the patient. Next. Okay, so the asthma action plan is recommended for the moderate or severe asthma, any history of the severe exacerbation and also poorly controlled asthma, and it consists of recommended doses and frequency, how to adjust the medicine at home, symptoms, emergency telephone numbers, a list of triggers, and also peak expiratory flow monitoring. Next. For the severity and also assessment, so in the newly diagnosed asthma, we can categorize it into the intermittent and also persistent. And under persistent, we have mild, moderate, and also severe persistent. And this category is based on the parameters such as daytime symptoms, nocturnal symptoms, exercise-induced symptoms, and also exacerbations. And the last one is the normal lung function. And the patient who having the persistent asthma should be started on the daily preventive medication. For the initial medication and dosage, will depends on the severity and necessity to attain the quick control of asthma. Next. For the long-term asthma monitoring and follow-up, during each visit, there are 3 issues that need to be assessed. So the first one is the asthma control, asking about the interval symptoms, frequency and severity, mobility, quality of life, and also the peak expiratory flow rate. For the compliance, ask the patient about the frequency of the usage of the medication and also the technique, and then the asthma education, including the understanding asthma in childhood, but emphasize compliance to therapy and return asthma action plan. So the patient with high-risk asthma will at risk to develop the near fatal asthma or fatal asthma. Next. So this is the high-risk asthma group, including the poor asthma control, require more than 3 medications, excessive reliance on bronchodilator, frequent nocturnal attacks, inadequate treatment or poor adherence, frequent visits to emergency department, previous ICU admission, denial of asthma, failure to perceive severe symptoms, and immediate asthma symptoms reaction. Next. Okay, so the patients who are already on the treatment, we need to be assessed at every clinic visits on the level on the control of asthma, which it is based on the Global Initiative for Asthma 2018, and the symptoms which is in the past 4 weeks, including the daytime asthma symptoms, nocturnal symptoms, behavior that needed for the symptoms, and any activity limitation due to the asthma. In the well controlled, there will be no of these symptoms. Partly controlled, there will be 1 to 2 of these symptoms, and in uncontrolled, there will be 3 to 4 of these symptoms. Next. Okay, so for the differential diagnosis, for the chronic cough and recurrent wheeze, we have upper airway disease like allergic rhinitis, sinusitis, and vocal cord dysfunction. Obstruction of the large airway like foreign body in trachea and bronchus, obstruction of the small airway like viral bronchiolitis, obliterative bronchiolitis, and bronchiectasis, and other causes like recurrent cough due to GERD, aspiration from dysfunctional swallowing, immunodeficiency, and tuberculosis. Next. So this is my references. I think that's all from me.
Any questions for
So next, we're
Zaza?
going to discuss on it.
Any questions for Zaza? No. Yes, no.
I have a question. Is there any correlation or is there a preterm birth has risk to develop asthma?
Zaza answer.
I think premature baby may have the risk because I think they may have small airway diameters compared to the mature baby. So this may predispose them to have asthma.
Okay, in the first place, right, when you are premature, depending on how premature you are, usually the ones that the premature babies who tend to have respiratory problems, they would go on to develop bronchopulmonary dysplasia rather than asthma, isn't it? Alright, so don't conflate the two things. But that being said, I think there were studies done that showed that premature babies have a higher risk of developing asthma. But whether you Is asthma really asthma per se, or rather consequence of the prematurity, meaning the child had oxygen dependency, developed bronchopulmonary dysplasia? That's a different entity altogether. Next.
Next, we're going to discuss on the topic of bronchiolitis. Next. This is the content of the topic. Next. What are the definition of bronchiolitis? Based on Nelson, bronchiolitis is an inflammation of bronchioles causing obstruction and collapse of the small airways during expiration. Meanwhile, according to UpToDate, bronchiolitis is defined as the clinical syndrome that occurs in children of less than 2 years of age and is characterized by upper respiratory tract symptoms followed by lower respiratory tract infection with inflammation which results in wheezing or crackles. Next. So usually bronchiolitis typically affects children and infants of less than 2 years of age, and the peak incidence is between 2 to 6 months old. It is a seasonal disease and commonly worldwide during fall and winter. Bronchiolitis remains as the significant cause of respiratory distress during first 2 years of life, and also it is one of the leading cause of hospitalization in infants and young children. And in Malaysia, it is endemic throughout the year, but the outbreak is more commonly seen during rainy seasons. Next. So the etiology of bronchiolitis. The most common cause of bronchiolitis are respiratory syncytial virus, which contributes about 50% of the cases. Next is the adenovirus, rhinovirus, myxovirus, parainfluenza virus, human metapneumovirus, influenza virus, and also coronavirus. Next. So this is the pathogenesis of the bronchiolitis. But before we begin with the pathogenesis, let us recall the gross anatomy of respiratory tract system. So respiratory tract is divided into two parts, upper and lower respiratory tract. For the upper respiratory tract, it consists of the oral and nasal cavity. And the lower respiratory tract begins with the larynx, pharynx, trachea, bronchi, small bronchi, bronchioles, and alveolus. So in normal bronchiole, the muscles are relaxed and the airway is open. But if the patient is infected with RSV virus, they will have early bronchiolitis. They will have an increase in mucus secretion and inflammation of the bronchiolar lining results in narrowing of the airway. And then the disease will progress to late bronchiolitis, which results in the increase in mucus secretion as a result of the cellular necrosis. Thus, it will lead to further airway congestion. Next. This is the detail of how the respiratory syncytial virus infect the upper respiratory tract and then spread to the lower respiratory tract. First, RSV, respiratory syncytial virus, is actually a single-stranded RNA that is spread via airborne droplets or direct contact with the respiratory secretion. And then if it infects the nasopharyngeal cell, it will replicate in the nasopharyngeal cell, and then the nasopharyngeal cell will slough off and being aspirated, carrying the RSV virus to the lower respiratory tract cell, which is in the bronchial lumen. So in the bronchiole, in the lower respiratory airways, the virus will replicate, which causing the inflammatory response, will causing the inflammatory cell infiltration, submucosal edema, increase in mucus secretion, and impaired ciliary action. And then the infected cell will be sloughed off and then causing the airway to be obstructed. When the airway is obstruction, there will be a expanded alveoli with trapped air. Yes, the sloughing of the RSV infected epithelial cell will accelerate the elimination of the virus of the infection, but it also contributes to the obstruction of the airway. And then the trapped air, the trapped air will be absorbed into the circulation, and then there will be no air in the alveoli, so the alveoli will be collapsed and causing the atelectasis. Next. So this is the pathophysiology and clinical features of bronchiolitis. The host with risk factor or does not have risk factor is exposed to the pathogen, and then causing inoculation of respiratory tract. First, to the upper respiratory tract, the virus will first infect the epithelial cell of the nasal airway and causing rhinorrhea as the initial manifestation. Then the patient will enter the prodrome phase, which within 4 to 5 days, when the immature active immune system in the infants fail to clear the virus in upper airway, and then the virus replicates and transfer to the lower respiratory tract. So the patient will have lower respiratory tract symptoms such as cough due to the inflammatory trigger of the irritant receptors, tachypnea, lethargy, and poor feeding. Also, patient will be having dehydration as the consequences of the response. Next, patient will enter the acute course. About 3 to 7 days. In infants, the airway diameter is smaller, so it will predispose to the airway obstruction, as flow rate is inversely proportional to the radius. Means that if the airway lumen is narrower, the flow rate will be lower, so it will cause lower obstruction. The lower obstruction mainly caused by the inflammatory response with the peribronchial edema and also mononuclear infiltrate. Also, obstruction is because of the sloughing off of the epithelium, which causing the varying degree of the obstruction. Next. So the airway obstruction will either cause complete airway obstruction, vacuum mismatch, and dynamic airway obstruction. So after that, the patient will enter the resolution phase. After the acute course, the infants usually recover spontaneously with the supportive measures such as hydration and antipyretics, and the recovery course takes about 1 to 2 weeks. Reinfection is less severe in the resolution phase, as IgG and mucosal IgA will be generated against the virus. However, 50% of patients have residual chronic wheezing that is caused by Th2 response to the RSV infection. Next. So to diagnose bronchiolitis, we have to take the history and also elicit the signs from the physical examination. So in the history, we have to know the clinical manifestation, risk factor, and also complication. So what are the clinical manifestation? It has a two part, early and late. So usually it will preceded with upper respiratory tract infection, which are coryzal symptoms such as nasal congestion, discharge, mild cough. And also patient will have low grade fever. And for the late manifestation, the patient will have a lower respiratory tract signs and symptoms such as persistent cough, wheezing, tachypnea, subcostal, suprasternal, and intercostal recession, and also have hyperinflated chest. Next. However, in clinical manifestation, we have to elicit the signs of severe life-threatening illness, such as central sinuses, tachypnea, lethargy, and apnea. Next. Features of bronchiolitis is divided into mild, moderate, and severe. How the classification of the disease is based on the manifestation. In mild disease, the infant is alert and active. The feeding is well. There is 9 to minimal intercostal retractions. The respiratory rate normal to mildly elevated. In moderate disease, the infant is alert, able to be consoled. Feeding is decreased. There is minimal to moderate intercostal retractions. The respiratory rate mildly to moderately elevated. In severe disease, the infant is fussy, difficult to console. The feeding is poor. There is moderate to severe intercostal retractions. and the respiratory rate moderately to severely elevated, which is more than 70 breaths per minute. Next. So this is the risk factor to develop severe bronchiolitis. If the patient is premature, low birth weight, have chronic lung disease, age less than 12 weeks, have hemodynamically significant congenital heart disease, have anatomic defects of the airways, and if the patient is immunodeficiency, then the infants, the children will have risk to develop a severe bronchiolitis. Next. Majority of the children that have viral bronchiolitis have mild illness. However, about 1% of the patient have to require hospital admission. So the children that require hospital admission are those who age less than 3 months, have a toxic looking, have moderate to severe chest recession, central sinuses, wheezing, crepitations on auscultation, have difficult feeding, apnea, the oxygen saturation less than 93%, and among the high risk group. So all these characteristics, if the patient have all of this, the patient have to be admitted for hospital management. Next. So these are the complications of bronchiolitis. First is dehydration, apnea, and respiratory failure. So respiratory failure, there are two types, type 1 and type 2. For type 1, it is a hypoxemia associated with mucus plugging and antelactasis. For type 1 respiratory failure, it may respond to supplemental oxygen alone. However, if the patient is developed to type 2 respiratory failure, the patient will require additional respiratory support such as intubation and mechanical ventilation. Next. So this is the to know the signs of the bronchiolitis, we have to do physical examination. So the general examination, we have to look for the signs of bronchiolitis such as sharp and dry cough, nasal flaring, severe grunting, tachycardia, tachypnea, cyanosis, and dehydration. In respiratory examination, on inspection, there is presence of hyperinflated chest with tachypnea, subcostal and intercostal recession. On palpation, there is presence of palpable bronchi, diminished type vocal parameters. On percussion, there is presence of hyperresonance on both sides. On auscultation, there is diminished air entry, vesicular breath with prolonged expiratory phase, generalized bronchi, and fine and inspiratory crackles. Next. See, these are the signs of the bronchiolitis. Next. For investigation, in bronchiolitis, bronchiolitis can be diagnosed clinically. However, we can do investigation to monitor and also to rule out other causes. First, we need to perform full blood count to indicate either the causes of the bronchiolitis is caused by viral or possible bacterial infection, and also we have to perform pulse oximetry to assess the oxygen saturation, and then arterial blood gases to check if there any impending respiratory failure, chest x-ray to assess the hyperinflation and atelectasis of the lung, and also to rule out pneumonia or other causes of other causes. Next, nasopharyngeal swab to detect the viruses by immunofluorescence technique. Next. So for the chest x-ray, it is not routinely required, but it is recommended for children with severe respiratory distress, unusual clinical features, if the patient have underlying chronic respiratory disorder, and also if the patient is admitted to intensive care unit. And this is the features of the chest x-ray in patient with bronchiolitis. They have patchy atelectasis, in particular of the right middle lobe, bilateral peribronchial infiltration with air bronchogram, and in the picture B, there is hyperinflation of the lungs with flattening of the diaphragm. Next. So the differential diagnosis are bronchial asthma, viral pneumonia, recurrent viral induced wheeze, foreign body aspiration, chronic lung disease, bacterial pneumonia, aspiration pneumonia, and also congenital heart disease. Next. So for management of bronchiolitis, there is divided into supportive and pharmacological. For the supportive, general measures, we have to assess the SpO2 level, and the SpO2 level should be maintained above 93%. If it is below, then if it is lower, then we have to give oxygen supplementation. Also, we have to monitor for signs of any signs of impending respiratory failure, such as increase in oxygen, reduce in oxygen saturation despite of oxygen supplementation. And then in a very young infant of less than 4 months old, we have to closely monitor the patient, as the patient have high risk of apnea, and we have to tell the patient to limit the direct seat contact, and patient need to have influenza virus vaccination for a patient of more than 6 months old. Next. For nutrition and food therapy. For management of bronchiolitis, for mild disease, usually it is resolved with hydration and antibiotics only. But if it is moderate to severe, we have to manage more. So if the patient have moderate respiratory distress, we have to give a small frequent feeds to the patient. And if the patient is refused orally, so we need to insert nasogastric tube for feeding. And if the patient have severe respiratory distress, sinuses and apnea, we have to give IV fluids for the children. Next. For pharmacotherapy management, we have to give 3% saline solution via nebulizer, as it can increase mucus clearance, and we can give inhaled beta-2 agonist as it can improve the symptoms of the patient, and we can give inhaled steroids. However, in the inhaled steroids, the data shows no meaningful benefits. And for prevention, we can give intramuscular monoclonal antibody to RSV F protein, and it can be considered for infants of less than 2 years old with chronic lung disease, history of prematurity, and hemodynamically significant congenital heart disease. This is to prevent for the patient to have bronchiolitis. Next. So the prognosis of bronchiolitis, usually it will recover over 7 to 10 days, and 90% of the children with bronchiolitis will discharge well. And but wheezing may last for 3 to 4 weeks as the response of the Th2 receptor, and 50% of the patient will have recurrent episodes of cough and wheeze over the next 3 to 5 years. Next. So that's all from me.
Yeah, any questions? No, then go to the next one.
I will continue the presentation about croup and epiglottitis. So this is my outline. So firstly, when we compare the adult's upper airway and child's upper airway, so based on the reason stated in this picture, so any impairment or any inflammation to the child upper airway will greatly impact the child ability to have a normal breathing. So in the second picture, we can see that although edema of 1 millimeter in children will greatly reduce the cross-section of about 75% compared to normal adult. So when we look at croup, so croup, or known as laryngotracheobronchitis, is a progressive spread of inflammatory process down the respiratory tract of larynx, trachea, and bronchi. So the pathophysiology basically is pathophysiology of inflammation. The inflammation at the trachea, larynx, and bronchi. So the increase indication, and then cause edema. So this edema greatly impact the airway opening. So we can look at the picture. The opening here is greatly reduced. So epidemiology, so this most common in children 6 months to 6 year old. So peak incident in second year of life. So highest cases occur in fall and in the winter. So severe in children are less than 3 years old. So male is highly susceptible, more than female. Then croup account for more than 95% of laryngotracheal infection. So etiology, the most common causes of this croup is parainfluenza virus type 1 to 3, which is 74%. And if you look at certain textbook, this disease is specifically known as viral croup. So other uncommon causes is adenovirus, intro, measles, mumps, and rare is mycoplasma pneumoniae and corynebacterium diphtheria. So for clinical features, symptom in early 12 to 72 hours. So first is low-grade fever, and then the common causes symptom, runny nose, sore throat. And then late symptom is inspiratory harsh stridor, barking cough, the seal cough, and then voice hoarseness and respiratory distress, which is varying degree that I will further explain that divide the symptom according to mild, severe, and mild, severe. And then sign on inspection, sign of respiratory distress, tachypnea, tachycardia, nasal flaring, respiratory grunting, head bobbing, and then there are suprasternal, intercostal, and subcostal sensation, and central cyanosis. Then on auscultation, there is a poor air entry, reduced breath sound, and expiratory rhonchi. So for diagnosis, so diagnosis of croup is a clinical diagnosis. So it is safe to visualize the pharynx, just to rule out epiglottitis, retropharyngeal abscess. And in severe croup, so the examination of the pharynx is done under controlled condition, which is in OT or ICU. And then neck radiograph is not always necessarily unless in doubt of such as rule out foreign body. So investigation, blood investigation, we can look at the white blood cell, which is will be high lymphocyte to see, and then increase ASR, indicate of the inflammation, and then pulse oximetry, we measure the oxygen saturation. So in less than 93% is considered severe. And then net radiograph, although not required but can be done. So they shown what we call as the steeple sign. So this is anterior posterior net radiograph. So if we look at the picture, so the normal one is the green here. So this is the laryngeal shoulder is present, but then in croup, we can see the steeple sign. So this loss of the tracheal laryngeal shoulders. So steeple is like this picture here. This is steeple of a church. And then in laryngoscopy, formed to rule out parietal abscess. So for management, so in for hospital admission is only required for moderate or severe group. And then for child which is less than 6 months old, poor or poor intake, toxic appearance, and live long distance for hospital. So for the severity, so for mild presence of stridor, and then there's no respiratory distress, moderate stridor at rest, plus intercostal, subcostal, or standardization, and then severe croup characterized by stridor at rest and marked recession, reduced entry, and altered consciousness. So this is the algorithm for treatment, which is based on the severity. If we look at whole, so most common is dexamethasone, which is given to reduce the inflammation, and then nebulize adrenaline, which can cause bronchodilation to reduce the symptom, and then budesonide, which also act like dexamethasone to reduce the inflammation. And then complication and prognosis. So complication common is hypoxemia and respiratory failure, and then secondary bacterial infection. And then prognosis is usually excellent because the illness in approximately 3 days will almost completely resolve, and then less than 3% of those who hospitalized need intubation, and then less than 1% of those intubate, less than 1% of mortality. Okay, next is epiglottitis. So the epiglottitis is the inflammation of the epiglottis and surrounding structure, the epiglottic fold and arytenoid soft tissue. So epiglottitis is a life-threatening emergency case because of the high risk of obstruction, has been explained before, because of the anatomical differences between dog and child. So epidemiology. So most common is the Haemophilus influenza B, but after vaccination, it has been increased greatly. So the decreased incidence is 5 per 100k dose of ages less than 5 years old, but then increased age of children with hepatitis within age 6 to 12 years old. So this is etiology. So the most common is Haemophilus influenza B, but because of the vaccination, currently others have been rising, such as the Staph aureus. So pathophysiology is also the pathophysiology of inflammation, start by the bacterial colonization and then penetration to the mucosal barrier, and then acute onset of inflammatory edema, and then edema rapidly progress, and then the edema will block the airway, but then because of the tightly bound epithelium on the vocal cords, it has edema spread at the vocal cord level. So clinical features of epiglottitis. So symptoms onset is very acute, which is high grade fever, 38.8 to 40 degrees Celsius, and then dysphagia, drooling, noisy breathing, short-term of prayer, muffled speech, or known as hot potato voice. And then uncommon presentation is cough because of the absence of the cough reflex at the epiglottitis. And then signs general, patient is ill and toxic looking, sit immobile, upright, and open mouth to optimize the airway, we call it as a tripod position. And examination, so it is not recommended to do throat examination with spatula, because of it can greatly increase the severity of the symptom. So examination of the throat is only done in the controlled environments with the presence of the okay. So this is the tripod position. We can look at the child sitting like this. Is actually to help them to breathe easily. So during this in this position, we can see the drooling of the saliva because of the any action such as eating or other can greatly induce pain in the child. So this is the epiglottitis triad: fever, dysphagia, voice, and then this body, dysphagia, drooling, dysphonia, and distress. So diagnosis, so also established on the basis of clinical history and sign of toxemia and upper obstruction. So it's a high mortality if diagnosis is delayed. So for investigation, firstly is if we suspect that any child is having epiglottitis based on the presentation, first we need to notify the senior anesthetist, pediatrician, and ENT surgeon. Perform a laryngoscopy in ICU or T. So the features in laryngoscopy is the cherry red, intense swelling of epiglottis and surrounding tissue. So, such as in the picture here, C is the normal one, and then B is the inflamed epiglottitis that completely block the airway. Then blood CNS can also be done after the airway is secured, and then the lateral neck radiograph can confirm but not necessary. So in lateral neck radiograph, what we can find is in the epiglottitis is this one is what called as thumb sign. So management of epiglottitis, firstly, patient have to admit urgently, and then to relieve the airway obstruction and eradicating the infection agent. So the need to prioritize the ABC, airway breathing and expiration. So if there are any arrest, the step is to administer oxygen therapy, and then secure the airway. Can be done by endotracheal intubation or cricotomy or tracheostomy, and then after that, give the appropriate antibiotics according to the infectious agent that has been determined. So complication and prognosis. So complication of hepatitis. First is the airway obstruction lead to respiratory arrest and death from hypoxia, then expiration, and then complication of the management itself, endotracheal dislodgement and tracheostomy. So in classic case of bacteremia, such as in the Haemophilus influenza, so other complication is such as the meningitis, pneumonia, septicemia, solitis, septic arthritis, and arthritis media. Then prognosis, both onset and clinical recovery are rapid. Most children extubated safely after 24 hours, and mortality rate is less than 1%. So based on all I have present, so all of the croup and epiglottitis have been summarized in this table. So the comparison, I think the most significant is the onset. So croup slow, epiglottitis is rapid onset, and then patient appearance unwell and toxic. And then other than that is fever, croup low grade fever, epiglottitis is high grade fever. And then other than that, yeah, you guys can read yourself. So this is my references.
Okay, croup and epiglottitis. You guys must know the differences. Croup tends to be younger, epiglottitis tends to be older. Epiglottitis, the children tend to be more toxic looking. It's not that fever part is not really the most significant, because generally the ones with epiglottitis, they are more toxic looking. They look generally more ill. Now, Zaid said something about diagnosis just now, visualization. Usually, it's just a clinical diagnosis. You tend not to want to look in the throat, because if you look in the throat and ENT is not standing by, you might cause get reflex, and then at the same time you get bronchoconstriction, total obstruction of the upper airway. So in which case you want to have to perform an emergency tracheostomy. So usually it's clinical. The kid looks ill. There's a bit of stridor. We start off with antibiotics. We are not going to do this. This part where you're going to ask the ENT to visualize. No. Okay. Any visualization is needed will be within controlled setting, meaning either you do it in the OP with the ENT team to stand by. Okay?
Okay.
Done?
Done.
Any question?
Hello everyone, can you hear me?
Mm-hmm.
Yes, okay. Okay, my name is Muhammad Hafizuddin Abdul Razak, and I will be presenting about childhood pneumonia. Next. Okay, first of all, pneumonia can be defined as infection of lower respiratory tract that involves the airways and the parenchyma of the lungs with consolidation of alveolar spaces. Next. Pneumonia can be divided into two types. First, bronchopneumonia refers to inflammation of the lung that is centered in the bronchioles and leads to the production of mucopurulent exudate, which obstruct airways and cause patchy consolidation. Second is lobar pneumonia, which describes the pneumonia that is localized to one or more lobes of the lungs. Next, interstitial pneumonia refers to inflammation of the interstitium, which is composed of the walls of the alveoli the alveolar sacs and ducts, and the bronchioles. Next slide. Okay, this is briefly the pathogenesis of pneumonia, which is started with the infection of the lung by etiological agents such as viral and bacteria. This will initiate inflammation response, which results in migration of inflammatory cells such as neutrophil out of the capillaries into the air spaces in order to kill the etiological agents. So it will lead to alveolar edema and exudate formation. The complex interaction between bronchioles will the complex interaction between microbes, cells of the lungs parenchyma and immune defense cells cause the alveoli and respiratory bronchioles filled with serous exudate, blood cells, fibrin, and etiological agents, which lead to consolidation of lung tissue. Okay, next slide. About the etiology, the specific etiological agents are not identified in 40 to 60% of cases. The majority of lower respiratory tract infection are viral in origin, and it is difficult to distinguish between viral and bacterial disease. But there is a helpful indicator for us to predict the etiological agents, which is by using age group. Okay, next. So these are example of etiological agents that involve infection according to the age groups. As we can see, different age group has different etiological agents. You can read and memorize it later. Okay, next. Okay. Regarding the clinical features, in neonates with pneumonia, they have very limited symptoms with subtle or absent in physical finding. So it is important to consider the diagnosis in this simple presentation or not to rule out the diagnosis unless we assess it thoroughly. In infants and children, commonly they present with fever, cough, tachypnea, malaise, retraction and apprehension because of difficulty breathing or shortness of breath, and also symptoms of pleural inflammation such as pleuritic chest pain and also abdominal and or neck pain. Okay, next. For physical examination, on inspection, a patient might have tachypnea and sign of respiratory distress such as grunting, nasal flaring, retraction, and use of accessory muscle. On palpation, there will be reduced chest expansion and increased tactile parameters, dull on percussion, on auscultation, decreased breath sound, bronchial breathing, and inspiratory crackles, and increased vocal parameters. Okay, next. Okay, these are pictures show signs of respiratory distress. You can read it later. Okay, next. Okay, clinical features also can help to assess the severities of pneumonia. Children aged below than 2 months, they are considered severe if they present with chest inrowing and tachypnea. And it is considered very severe if they are not feeding, having convulsion, abnormally sleeping, difficult to wake, and fever or hypothermia. In children with age 2 months up to 5 years old, they are considered mild if present with tachypnea only. Severity increase if associated with chest inrowing, and it will be very severe if they are not able to drink, having convulsion, drowsiness, and malnutrition. Next. For investigation, first, we can do chest X-ray. It is indicated when clinical criteria suggest of pneumonia. However, it does not differentiate etiological agents and not always necessary if facilities are not available or if pneumonia is only mild. Usually, we expect to find in the X-ray is consolidation, pleural effusion, hyperinflation, and also increased interstitial marking. I will show you the example of chest X-ray with pneumonia after this. Second is FBC, full blood count. We expect to find elevated white blood cell. If predominantly polymorphonuclear monocytes, it suggests bacterial infection. Next is blood culture. It is non-invasive gold standard to determine precise etiologies. However, it has low sensitivities with 10 to 30% only of patients have positive results. So it is indicated if pneumonia is severe and poor response to first-line antibiotic. Next. The fourth one is renal profile, which may show hyponatremia. Pleural fluid analysis, if there is pleural effusion, and also serological tests we perform in patients suspected of atypical pneumonia. Example of atypical, not typical, atypical pneumonia. Example, infection by Mycoplasma pneumoniae and chlamydia. And this test also this test also can be considered in patients with age 5 years or older. Okay, next. This is example of a chest X-ray of pneumonia patient, where there is a presence of in the first picture on the left side, presence of hyperinflation in the infection of virus, and also on the right side is the consolidation of the lungs. Okay, next. Okay, for management, we can provide supportive and pharmacological measures. For supportive, first, withhold oral intake in patient with severe respiratory distress. And usually in severe pneumonia, secretion of ADH is increased, so dehydration is uncommon. Instead of overhydrating the, avoid overhydrating the patient. Okay. Next is maintain SpO2 more than 95%. Control the temperature to reduce discomfort of symptoms, and lastly, do chest physiotherapy to remove tracheobronchial secretion that obstruct airways, but this one there is no evidence it should be routinely done. For pharmacological, in viral, no specific medication, while in bacterial infection, as usual, prescribed with antibiotic. Next. Okay. Not all patients need to be hospitalized. There are certain conditions or criteria for hospitalization of patient. Okay. First, if patient age is less than 3 months, whatever the severity. Next is fever more than 38.5 degrees Celsius and refuse to eat and vomiting. Fast breathing with or without cyanotic, failure of previous antibiotic therapy, recurrent pneumonia. Lastly, severe underlying illness, example, immunodeficiency. Next. Okay, this is a table shows suggested antimicrobial agents for inpatient treatment of severe pneumonia. First line is beta-lactam, for example, benzyl penicillin or amoxicillin. Next, we can consider second line antibiotic if there are no signs of recovery and patient remain ill and toxic with spiking temperature of 48 to 72 hours. So the second line antibiotics, for example, cephalosporin such as cefotaxime and cefuroxime. Okay, next slide. Okay, this table shows suggested antimicrobial agent for the patient if we found the specific pathogen. But as I mentioned earlier, 40 to 60% of cases not identify the specific etiological agents. Okay, next. Okay, for outpatient management, usually in children with mild pneumonia, we can prescribe with oral antibiotic and then educate parents or caregivers about the management of fever, preventing dehydration, and identify a sign of deterioration, and return in 2 days for reassessment or earlier if the condition is getting worse. Okay. Next slide. Okay, these are some examples of complications that may happen in a pneumonia patient. There are parapneumonic effusion, empyema, lung abscess, and bronchiectasis. I think that's all from me. Thank you.
Any questions? Any questions? No? Any questions? No? Yes or no?
No question.
No questions.
So, posting habis bila? Posting habis bila? No,
Next
posting
week.
bila? Next week. Mana? Okay, kalau tak ada tu. Okay.
Thank you, Doktor.
Okay.
Thank you, Doktor.